Good morning and welcome to the board meeting of Nottinghamshire Healthcare NHS Foundation Trust. My name's Paul Devlin, I'm the Trust Chair, and you're very welcome joining us either watching live or indeed watching on a catch-up version. As always with our board meeting, we like to frame our meeting with some real life experience of patients, carers, staff, and today I'm delighted that we're going to spend some time hearing about the experiences of some staff on digitisation of patient documentation at our Lings Bar Hospital. So what I'm going to do is hand across to Kathy Fullaway and Teresa Brennan, Angela Gamble to give us some of your experience of digitisation. Kathy, I think it's over to you to start.
Great, thank you very much, Paul. Hello everybody, I'm Kathy Fullaway. I'm the Trust's Chief Digital and Information Officer, and we've been working collaboratively on our digital health strategy recently. The aim of that is to provide digital solutions that help improve people's health and well-being. And so there's a number of initiatives that we've been undertaking and will be undertaking in the future as well, around providing digital health solutions and digitally enabling the transformation work that we do as a trust, but also with other health and care providers locally to us. And the aim of those digitally enabled projects is that ultimately we benefit patients. So we hope to introduce improvements. Things like once information is electronic, then it can be used wherever and whenever it's needed by whomever needs it. And that hopefully would reduce the time it takes to move paper around, which ultimately slows things up for patients. We'd also hope that we improve the quality and the richness of the information that's available to our staff so that we can provide better patient-centred care, and that those who need that information have that available to them when they're making important decisions, so that patients and staff can use that information together around improving their care. And at the same time as doing those projects, we'd hope we can improve processes, so perhaps reducing time it takes to complete documentation, for example. So we'd release staff time to do the thing that's really important, and they can spend time with patients. So at Lings Bar Hospital, as Paul said, we've been doing some digital work. They were predominantly on a paper-based system. We did use a couple of electronic systems just to supplement that paper system, but there was a whole mix of them. And so we've moved to a single electronic system that works nearly complete. So I'm going to introduce Teresa and Angela, who can help describe the benefit that it's having to patients and some of the opportunities for how we can see even more benefits in the future. So Angela Gamble is one of the ward managers at Lings Bar. Teresa Brennan is practice development nurse, and it's over to you two. Thanks.
Good morning. As Kathy says, I'm Angela. I'm ward manager on John Proctor Ward at Lings Bar, and this is Teresa Brennan, who's our practice development lead. So in May 2021, we made the switch to digital, and we are now totally digital in our nursing, therapy and medical records. The only major exclusion currently is with the medications prescribing and administration, and there are plans within the trust to address this also. To help you picture the patient experience at Lings Bar, the majority of patients come from the acute care and are known to the community services, at least a GP before that. This usually means that there are several health and social care teams involved in supporting the patient in the community. Prior to digitisation, the sharing of information between these different teams was difficult and disconnected, which for the patient meant they had to repeat information to different professionals during their journey from home to the acute, to rehabilitation and then back home again, which they and their families found very frustrating. It led to a lack of confidence in us, where it appeared no one saw the full picture or talked effectively to each other. This is also ate up time, taking information multiple times by different professionals when that time could be better used for patient care. We recently had that issue arise on the ward. A daughter of a patient we had admitted did say to us that they were not willing to repeat the information for their patients for their parents' information again, because they've been asked to do so many times, and it was all documented in the notes from QMC. They were quite angry about it, and they're quite understandably so. So that we had to then go back in and check this information out so we could then put it onto our system so not repeat ourselves again. Care wasn't as patient-centred or as prompt as we'd like, due to information not being able to be shared quickly or easily across these many teams. There were at least 3 to 4 different electronic and paper documentation systems within the wider healthcare system, so each team would have gaps in their knowledge, missing details which would help them to better understand and support the person. Each team was given a summary of care events at transition which could not contain all of the details, meaning these were either missed or had to be asked for. This then led to affecting the seamless continuity of care we and the patients want. The patient benefits we're already seeing from the digitisation work at Lingsbar are patient confidentiality. Goes without saying that notes being electronic rather than on paper helps keep everyone's information safer. As we are now continuing the patient's community records, we are asking patients questions like, can I confirm, rather than tell me again. This makes patients feel more confident and safe because it is clearly we have key information about them already. This also speeds things up. Sharing the community information means that we are quicker to assess and quicker to move forward in treating and supporting the patient. For most patients, getting home is paramount, so the quicker we can start to work with them to live with or recover from their conditions, the better. Patient care, and particularly discharge home, is safer and better planned. Previously, we wouldn't be able to see all the notes made by the GP or community teams, so we were relying on information from the patient and their family, which sometimes didn't include key factors and was solely from their perspective. We didn't realise they had access issues or hoarding issues, as they did not see this themselves. For example, when a patient asked, how are you managing at home, they may well say things they're fine, they have no problems, but now we're able to see that this patient had difficulties at home, perhaps has fallen multiple times and struggles with daily tasks of looking after themselves, and has required a lot of community nursing support. This is vital to make sure our patients are safe and supported appropriately when we discharge them. This is especially true in the current circumstances with limited visiting, where families can't have those unplanned conversations with us which help us understand the home situation better. This is also important for families and carers. Often the last thing they saw was their loved one being taken off to Queen's in an ambulance. They've been limited opportunity to visit, and suddenly we're talking about discharge. They need to know that we have understood their circumstances, know what we're doing when we start planning discharge with them. Having this information does not replace good communication with the families, but enhances it. As we can show we know the home situation well, it can instill a sense of confidence with the family and gives us a good foundation to work from. Patients will get more individualised care when they reach us. Being able to see all the patient's previous interactions with different services means we can tailor the support we provide in the full knowledge of what they really need, what has been tried, what they struggle with, etc.
One of the specific improvements for the patient experience has been the opportunity to bring together all the information to help reduce the chance of a patient falling. When assessing the risk of falls, the level of supervision a patient needs is a key factor, as having if somebody has a confusion or a dementia, it hugely increases the risk of a fall. Following digitisation, we can now work on a project to streamline our falls pathway to reduce duplication of assessment and to increase the sharing of information across nursing, physio, OT, medical and pharmacy teams much better. These teams carry out key interventions that impact on preventing a fall, but this information is scattered across different professionals' records and don't clearly link to each other. We can now bring all of this information together in a falls prevention care bundle so that each professional collects their information. As each professional collects their information, it will be visible to everyone else to see and use. Previously, trying to do this with paper records proved incredibly difficult. Close supervision for patients can be very intrusive and restrictive. Previously, there were in excess of 36 questions asked by nurses on admission relating to falls risk factors, but many of these were repeating information that were asked by other professionals, and none actually assessed the level of supervision nurses actually need to know to keep patients safe from the point of admission. So having gone digital, we've been able to trial an admission screening tool called a float that accurately assesses the level of supervision someone requires so that we can make it as least restrictive as possible and targeted to that person's individual needs. This replaces the blanket cohort or enhanced care label that the wider care system uses, but we at Lingsbar are moving away from. Still recognising that a level of enhanced care is required to maintain that person's safety, but being able to define more individually what enhanced care actually means for that person. Being able to focus on the information a nurse really needs to know, we've managed to reduce the initial assessment questions from 36 down to 6 specific questions, as all of the others are being covered by other professionals' existing assessments, and all this information will now be visible to nurses and others in the care bundle. Using these 6 questions, we can quickly and accurately assess the supervision level required, placing the patient in the right bed from the start. And as the patient progresses, we can reduce the level of supervision, enabling less restrictive practice. This kind of streamlining and closer sharing of information will improve both patient care and input into professional working still further at Lingsbar. Some of the additional patient benefits we hope to see but haven't quite as yet. We are going to have smaller handheld devices for patient observations, which will mean logging on quicker and making the interactions with patients less intrusive without the barrier of a laptop sitting between us. Connectivity is currently a major issue in the hospital. There are areas in the wards where information can be inputted and then lost as soon as you move. This is a huge waste of staff and patients' time, as it all needs to be repeated. To fully realise the benefit for patients, we need to be skilled in using the whole of the new system. There are still aspects that we're not using as effectively as we would like to be. So overall, our experience is mixed, from a very positive starting point with the development team who worked really hard to get to know what we did as a service to help create a system that meets ours and our patients' needs. And this was key to how we adopted the system so successfully. Through a difficult period of adjustment where we'd like to acknowledge the commitment of our staff teams to making the system work with as least impact on patient care as we could. Our staff range from the digitally terrified to the tech savvy, and they all work together to help master the system. It's been acknowledged that the training element of the project really let us down, but that's now being addressed. To our current position, where we continue to build our skills, but we're confident enough to start polishing elements within the system to work better for our patients and ourselves.
I'll admit that I was sceptical about the switch to digital. I'm really not a tech person and I did struggle. There's still elements of the system which I'm yet to be convinced about, particularly digital records taking less time than paper, because sometimes I feel it takes a bit longer. But overall, I'm a convert and I can see that this has the potential to make the patient experience safer and more joined up. Thank you.
Does anybody have any questions?
Fantastic. And Teresa and Angela and Kathy, thanks so much for giving us that description that was so very patient and family focused. And it's a really good reminder that the digitalization agenda isn't solely for staff. It's actually, this is about improving things for those who need and use our services. And I think you got that across really clearly. I will open it up. Jan, do you want to introduce yourself? I know you're the exec who's the portfolio holder for this. So I wonder if you wanted to go first, then Manjit, I'd like to invite you in. Jan.
Thank you very much, Paul. Yes, Jan Spencer, I'm the Executive Director of Partnerships and Strategy, and I lead the digital services. I just wanted to say a few words, really. In my background, one of my previous jobs was working in Staffordshire in Healthwatch, and one of the things that we heard from patients more than anything else was about that lack of join up, about having to tell their story over and over again. I can remember one lady had something like 9 different care plans. And none of them kind of talk to each other. And so I think this story really exemplifies how some of our enabling services really do directly impact on patient experience and can make things so much better, and how therefore important our enabling services are. One of the strands of our digital strategy that we're going to be bringing to the board next month is around patient-facing services, and I think this story has really helped the board to understand why we want to put such a lot of emphasis on those patient-facing services, because thank you, Teresa and Angela, you've done a fantastic and cracking job of really exemplifying what this means to patients, and I understand also there's some learning for us to do. We can absolutely take forward that point about training. I think even those of us that think we're reasonably savvy, there's always more to learn in the digital world, and we need to keep refining our skills, don't we, and improving our skills. So I completely understand the points you've made there, and that's great learning for us going forward. But I hope that this has really shown the board just how important it is that we have these enabling services that can improve patient care. So thanks very much to Teresa and Angela and to Kathy and her team.
Thanks, Jan. Manjit, let me bring you in and then just see if anybody else has got any questions or comments. Manjit.
Thank you. Manjit Dalmi, I'm a non-exec director and I sit on the improvement board for Lings Bar. And I just wanted to comment that actually I think that the digital programme is a really key enabler in terms of the action plan and the modernisation of kind of the delivery of care at Lings Bar. So, and the work that you're doing is brilliant. I mean, I think that the other thing for me is actually the difference in kind of, you've got some really key people who are drivers, and then you've got people who really struggle with the technology, and I'm really interested in kind of how we're bringing both components together to make sure that everybody's on the journey in the same way. And the other thing that I'm interested in is how the patients are responding to this agenda, and how patients are actually engaging and being used to think about technology, and just your comments on that. But you're doing a great job, so thank you. Teresa,
Angela, do you want to just respond to those bits about the patient side and getting all staff engaged?
I think the strength in getting all the staff engaged is the intergenerational teams, if I'm really honest. Young people grow up with this, they just throw themselves right in it, and they are the technology inquisitive people.
They taught us everything we know.
They were absolutely amazing. But I think there's also those other people who, I'm loath to say it because I'm one of them, but of the slightly mature people to whom it was like, oh my word, are you serious? And I can't tell you the dedication and the commitment of some of our staff, the healthcare assistants in particular, the real one-fingered typists who were so determined to grasp this. And I think having those two people together, working so well together, you'd see two people sitting there showing each other really patiently how to work the system, really. They were absolutely fantastic, and I think that sort of coaching model by peers was incredibly patient, totally focused on what people needed to do and understanding how to do it. They were also the people who would suddenly go, I've worked out this, look what you can do here, and look what's here. So their inquisitiveness then helped to take us forward in other ways as well. I would hope, if I'm really honest, Manjit, that patients didn't notice the difference, that us doing something as major as bringing in electronic patient records shouldn't have affected patient care.
No.
I think they were perhaps a bit amused watching us learning how to do it, so maybe we provided a bit of entertainment, but I think what it did do then, I think having that technology there when literally you'd come on the ward and everything that nurses and therapists did and doctors was on paper, this move to technology has made us look at things differently. So we now have set up a group. We've never had a carers involvement group really at Lings Bar, because our patients go through with an average length of stay of 21 to 28 days, and then they're back home. They don't really want to come back into Lings Bar and get involved and things like that. They want to get on with their lives, which is what we want them to do. But because we've got so used to using technology in teams, we've now got a carers group where we've just created a patient experience story and videoed filmed patients talking about what it's like to come into hospital and what they need from us. And we're using that as part of our staff induction, so that whilst they go and do all the trust values and the trust mandatory training, we do the local induction. what they also then hear from are patients who say, this is what's really important to us, this is how I felt when I come into hospital, how I feel when I come into hospital, and this is what I need from you. And here we can say it to staff about reassurance and compassion and patience, but when a patient's saying it to you, it holds that much more weight. So engaging using technology to create different resources on the ward that help us to better understand patients and carers is a really big step forward for us, and being able to use that technology to access relatives who can't get into hospital because of their own healthcare needs or distance and things like that. We're now much better at using that technology.
Thanks, Angela. That's a really, it's a really kind of comprehensive and holistic impact that you've described there. So thanks for that. Carolyn, if you, Carolyn, come in, and then I think we'll wrap up. Carolyn.
Thank you. Carolyn White, Non-Exec Director. Thank you, ladies, for your presentation. It's always great to hear about these progressions. Can you just share with us what you think were the 2 or 3 greatest kind of learning points that we can share with other teams as we roll this out?
I think for me, sorry, Angela, I think for me the most critical bit about rolling out any kind of thing like this again is the preparation from the implementation team, because they spent literally probably 2 or 3 months really learning what we needed to do and learning what we needed the service, the system to do in order to provide a service. But they also then recognised when they could make it better with technology, which we didn't know at that point. And I think that groundwork of process mapping what we did and then looking at a system that actually did that, I think that was absolutely key, because the thing that we had with the training was that they hadn't really been involved in that initial stage. So they were trying to teach us to do things we didn't need to do. Whereas when we went back to the implementation team, they understood what we needed to do.
I think for me, it's being able to look when a patient's put onto the system, we can look, see what sort of care they may need on the ward, what previously level they had, you know, ambulance call outs for falls and things like that. For me, having that background information is key, and I can also give the relatives a ring before they actually get on the ward, just so that we say they're coming here, this is what you can expect. So for me, that's been a massive bonus.
Thank you. Two really great learning points. Thank you.
Yeah, thanks very much. And I think, as Jan, you acknowledged at the start there, actually recognising the learning around the training phase. And I've heard that before with digital projects where, you know, we invest in the design a great deal, and then we just need to remember that investing in the training is absolutely critical, and doing that with good co-production so that the staff who are using this kit are able to influence it in the very early stages. Well, look, Teresa, Angela, Kathy, thanks so much for joining us at the board. It's really helpful getting that context. And as I said, I think you've also been really good at focusing it in on patients, families and carers for us, which I'm grateful for. So thanks so much for joining us, and have a good rest of your day today. Thank you.
Thanks. Bye-bye.
So if we can then move on to the rest of our formal business agenda, and to start off with a couple of welcomes and introductions, just to welcome Jen Guyver, who is here sitting in for Claire Teeney, and also Chris Ashwell, who's sitting in for Julie Atfield as well. So welcome both. I know we'll hear from both of you during the meeting. So apologies to note, obviously Claire and Julie, and also apologies from Trevor Orman and Shirley Higginbotham. So I think that's all of our apologies and notes of people around tables. So if I just pause and ask if anybody has any declarations of interest in relation to the public board agenda, please. I'm not seeing any. So in which case we'll move on then to questions received from the public, and as has been the case over quite a few recent months, we do get some questions that actually come from our staff that tend to be focused around different aspects of infection prevention and control, and also the impact of those restrictions and other COVID restrictions. John, do you want to just give an intro and then perhaps pass to Anne Maria? John.
Yeah, thanks. Morning, everybody. John Broom, Chief Executive. So there was a variety of questions this month. The one was around the side effects of the COVID vaccines, which I don't propose that we go into in a board meeting, but just to say that the Trust continues to adhere to all the guidance that we receive with regard to the use of these vaccines and medicines in general. So we wouldn't be making any independent decisions on that, and we continue to encourage all our staff to receive vaccines as the various age cohorts and booster programs come and go. There's then questions around social distancing and various infection prevention and control measures, which people will be aware that we have a different set of rules working in health compared to when we're not at work, which can sometimes be both perplexing and frustrating. But our resident expert on all things IPC is on the screen now. I'm going to hand over to Anne Maria just to give us a sort of summary update on where we are with use within our services. Thanks, Anne Maria.
Thank you, John. Yes, my name's Anne Maria Newham. I'm the Executive Director of Nursing, AHPs and Quality. And today I'm also going to introduce myself as the DIPSI, which is the Director of Infection Prevention and Control, which is why I'm often referred to as the expert. I do not profess to be an expert, but I have had to get my head around all of this over the last 2.5 years. We did receive a question around social distancing, and the gentleman, I'm really sorry, actually, I've assumed a gentleman, but it was anonymous, so my apologies if it's not. But the person would like to ask around why we're still doing social distancing and why has it not been removed. Now, the person also suggested that the IPC guidance had stated that we should return to pre-pandemic physical distancing in all areas. Now, I'm really sorry, but I'm not aware of that within healthcare. So I just wanted to reiterate that the guidance that was issued, where it still states for us, is called Infection Prevention and Control for Seasonal Respiratory Infections in Health and Care Settings for winter 21 to 2022. It was updated and issued on the 14th of April 2022. And it says around physical distancing in health and care settings, physical distancing is the recommended distance that should be maintained between staff, patients and visitors. The World Health Organization continues to advise that a physical distance of at least 1 metre should be maintained between and amongst patients, staff and all other persons in healthcare settings. This distance should be increased wherever feasible, especially in indoor settings, and physical distancing is recommended to remain at 2 metres where infectious respiratory patients are cared for. Now, the problem for us as an organisation is that we have advised that distancing remains at 2 metres in the inpatient settings, and that's due to the fact that we do not have dedicated respiratory infection, respiratory pathway wards or treatment areas. So we may be nursing positive patients on our wards. So that's all around social distancing. I hope that answers any questions that have come through. The next question that we received was around what is the logic behind ceasing testing visitors but continuing to wear masks. And the suggestion from this person was that masks do not prevent transmission. Again, I'm really sorry. We follow the national guidance. That's not for us as an organisation to decide to do something different. we have to follow national guidance, and they are really clear that we must continue to wear masks. And to be honest, I'm struggling a little bit with the fact that the person thinks that masks don't prevent transmission when we have a lot of evidence to show that it does prevent any transmission and moving from one patient to the next or staff member to the next. So we are continuing to wear masks. With regards to ceasing testing visitors, that is because they are wearing masks. And also, we are asking visitors if they are coming into areas of vulnerability or patients that we're a little bit concerned about. We have asked visitors if they would be able to do lateral flow testing still for us. So again, I hope that answers those questions.
Thanks, Anne-Maria.
Well,
John.
there was one final one, which was around access to the multi-faith room at Highbury Hospital for patients, which is a technically detailed question. So I haven't got the answer to that today, but we will be able to have a look at making sure that we can make that availability as good as it can be within the guidelines that Anne-Marie has just described. And if there's things that we can do to enable better access for people, we'll get onto that straight away. Thank you.
Thanks, John. I know much of the drive for these questions is about concern around patient experience, which we all absolutely understand and indeed share in terms of our reflections over many, many months of the impact on those who use our services of the pandemic. So thanks for those. If we could go then to the minutes of our last meeting from last month, and if I can just first ask colleagues for an indication if you're content these are an accurate record, please. Nigel, is your comment a query against accuracy or a piece to follow up? I know Anne-Maria was going to come back on something.
It's a typo, I think, Paul.
Okay, just grab that one for us, please.
Page 9.
Yeah. It's
got about halfway down. CW referred to the turnover of staff, which sat at 80%. I think the board would expect the chair of the finance committee to be a bit worried about numbers. I think that was 18% and not 80.
Okay. Yeah, that's probably an important one for us just to correct for the record, Nigel.
Yeah, thank you.
So if we note that one, and then otherwise people are content with those. And then if we go to matters arising in the action log, Anne-Maria, you'd indicated you'd got a matter arising.
I do, thank you so much. It's on page 8 and it's basically in response to Nigel. Nigel posed a question around concern around upheld complaints, partial and upheld complaints. I thought it was a really valid question, and it made me think a lot about our position with regards to benchmarking across other organisations and whether or not we were doing the right thing. So myself and Ian Pegg have done a little bit of research on the back of that question posed, and it was just to say that when we talked about it, we were at 41%, which was February. When we come to it, when we come to the integrated performance report, it'll show at 30% for March. So I just wanted to say at 41% we were, 30% for March. However, in doing a bit of benchmarking across other organisations, I just wanted to let you know that I think we fare well. So Lincolnshire Partnerships at 47%, Derbyshire Healthcare is at 47%, Humber is at 62%, and Plymouth is at 50%, Southampton's 53%, and Royal Free is at 71%. So I think that at 41%, in fact, that makes us the best, and at 30%, it makes us even better.
Great, thanks very much, Anne-Maria, and really appreciate you sort of taking away a reflective action like that. And the action log, everything has been greened in the action log. So unless anybody's got any other comments or questions to pull out for that, let's move on, if I can, to my report. And I think the big thing for me is just to acknowledge that we've finally reached the end of the inspection that had taken place by the Care Quality Commission, the CQC. It's actually been over something like 12 weeks because it's quite a substantial inspection that's taken place, including a chunk on well-led a couple of weeks ago. And I just wanted to acknowledge that the CQC were really impressed with the way that all of our staff that they spoke with engaged with them and were able to be talking about their services and what they were seeking to improve, what they were improving, just stuff that they were proud of. And really want to thank everybody who worked in conjunction with the CQC on this inspection. And that includes people who also met with them in focus groups, including some of our governors. And that's a really important piece for the CQC to triangulate what they hear from staff with what they hear from other staff, particularly when they're comparing on the well-led what they hear from senior leaders with staff on the front line. So it will be a while before we hear back from them more formally, and I'm sure John will mention a little bit more about this as we go through the meeting. And also just to pick out as well, our Black Minority Ethnic Staff Network has an annual report that will be coming to our People, Culture, Equality, Diversity and Inclusion Committee, and then we'll come to the board in due course. And I was really pleased to continue to be meeting with leaders of that network. It's a really important space for us to be constructively challenged on what we do as a board, and for them to be able to work alongside us rather than feeling like it's just them driving our work on anti-racism. So I'll pause there just in case there are any comments or questions. And if not, let's move on then to the Chief Executive's report. John, over to you, please.
Thanks, Paul. There we go. Yeah, so not a huge amount to go through today, and some of the headline stuff follows on from you, Paul. In my summary, I've put that we seem to have experienced a lot of sort of external commentary and inputs over the last couple of months, and if you link the results, for example, of the National Staff Survey and some of the initial feedback from the CQC, and then start to think about our recently launched 5-year strategy, the changing landscape of the whole of the NHS, which with the various integrated care systems becoming formalised in July, it starts to set out quite a clear, not just direction, but some detail in terms of some of the things that we really need to now prioritise and focus on over the coming months. Reflecting on that, this report, as often is the case, already out of date. So people will have seen, for example, that the Health and Care Bill, that is the legislation that's behind the ICSs, received assent last week. So with a fair wind, those plans for them to become real entities in July are on track. A bit of detail. As Paul said, the CQC have been with us since the beginning of February, and we completed the well-led last week and got some very high level verbal feedback, which will then be worked up by the CQC, and we will expect to receive the draft report from all their inspections towards the end of May or early June. We then have 10 days to check factual accuracy, and then the report is published. So I would think a publication date to sort of early mid-June will be expected. The only sort of outlier of this is that the current or the recent inspection team didn't have high secure services as part of their portfolio. So Rampton high secure services remain uninspected, but we do know that the CQC are inspecting all 3 high secure services this calendar year. And given that it's been so long and so much work gone into addressing the issues at Rampton and more broadly, it would be good to get that completed too. So that not that we have a letter, but that just gives us, but also the organisation, a bit of a breather from the CQC inspection. And just to reiterate your thanks, Paul, to everybody that's been involved across all the 3 clinical divisions and across the corporate enabling services to enable us to host that inspection over the last 3 months or so. It's been a phenomenal effort, and I know that we've been able to showcase some really great services for people. One other thing that again wasn't complete in time for the written report, and as a bit of feedback from the interviews that we carried out last week. So I'm really pleased to welcome Jen Gwyver to the Exec Director of People position. She was successful against a strong external field and will formally commence her executive role at the beginning of June. And likewise welcome Alison Wild, who the day after was successful in the Executive Director of Finance and Estates interviews, again against a strong external field, and will also be formally commenced in the post at the beginning of June. I know that the board already know Jen and Alison, but a real warm welcome, and look forward to working with you both. In the rest of the report, I just wanted to pick out on page 16, 17, top of page 17 actually, some of the work that's going on in the mental health division, and there's quite a bit of detail there. The latest wave of the pandemic in terms of the sheer numbers is abating. Staff absences are reducing, outbreaks are reducing, but we still have various hotspots across all the divisions actually, but mental health is still operating at this what's called OPEL 4, so the operating escalation level, which is the highest level. So real challenges in terms of demand and acuity of patients requiring admission. And this isn't just within Notts Healthcare, it remains a national issue. And routine community work there is deferred to ensure that there's a real focus on supporting people in crisis if they're having to wait for admission. So still, despite the good news around the COVID numbers, still an awful lot of challenge, both within the mental health division, but also across the systems too. I'm sure people are seeing it on the news, for example, in primary care and in emergency departments, for example. But just the other thing to highlight about that is some of the work that is going in this division with other stakeholders. So the appointment of 5 double impact peer support workers. Double Impact is a drug user charity. There's work going on with Mind to again support our community offer, and there's also good news on having additional funding for something that's called IPS, so individual placement and support workers, to help people in recovery to get back into or to maintain their work and employment. So some really good bits of work going on there that I wanted to highlight. And then finally, in the a couple of things from the communication update, Paul. There's I just wanted to flag on page 18, about halfway down, the trauma conference. So Steve Regal is one of our what is he? He's a mental health nurse by trade, but he's got a national and international reputation around work, psychological work in all sorts of trauma and resilience. And his team have organised this conference in July, at which Terry Waite is a keynote speaker. So look out for that and support it where people can. And then finally, from me, just wanted to flag on page 22 under our awards, as well as positive stars, just on page 22 and 23 to flag the NHS Parliamentary Awards. So this is where, as people can see, local MPs will put forward various services that are in their patch for the Parliamentary Award. So it's great to see that being a big, long list. And well done to all those other people that have won various awards. We were in national awards, national shortlisting, and great achievements for many of our staff colleagues. Finally, our comms team have just said to remind what a huge recruitment campaign that we were involved in over the weekend. Big ads in Mansfield, and a huge, I don't know if anybody was in Nottingham on Saturday, on the big screen outside Victoria Centre, an advert to come and work in mental health services. So it's good to see us using some different outlets for that. That's me, Paul. Thank you.
Thanks, John. Let's see if anybody's got any comments or questions. Stephen, please.
Thank you, Chair. Stephen Jackson, Non-Executive Director. It was not a question, you'll be pleased to know, John, just a comment that came out of last week's meeting on the Transition and Risk Group around the ICS. And that during the passage of the Health and Care Bill, a number of amendments have gone through, one of which I thought was quite important, and is that there's now a new requirement to have a dedicated ICB board member with knowledge and experience in connection with services related to prevention, diagnosis and treatment of mental illness. Which seemed to me to be a pretty positive development.
Yeah, thanks, Stephen. I just comment on that, and I think it's a really important amendment. There was some lobbying, both locally but also nationally, to get that in, because there'd been, I think, quite a variation across the country, and some boards had said yes, we needed a specified post, and others had said not. But that's a really good boon for mental health and learning disability services across the country, and really welcome it. Thanks.
Thanks. Paddy, please.
Paddy Tipping, Non-Executive Director. John's really helpful report. I was interested in the comms strategy that runs to several pages. Lots of work going on, lots of good work. But I just wonder what the three headline messages that we're trying to put across. What are the themes? What should we really be pushing throughout our comms strategy?
Thanks, Paddy. Great question. So, if I may, Paul, I might ask Yolanda to comment on that. I'll give it a go to start with. I think in terms of lining up with our overall strategy, I think one is that probably the most important is to for us to be recognising and celebrating all our staff's achievements. We hear, don't we, quite often in lots of comms nationally and regionally when things go wrong, but we've got 9,300 staff and more volunteers who are doing brilliant things day in, day out, and their professionalism and resilience, particularly over the last 2 years, has been quite phenomenal. And Yolanda and I have regular conversations about how we should always be looking out to recognise the great things that they're doing. In terms of the other priorities, I think I'd probably say one of them, Paddy, is connection. We are a huge and diverse organisation. You know, we've got national services in our high secure services. We've got you know, big centres from Rotherham to Leicester, and from the East Coast into you know, into Notts and further. And getting our arms around that from a communication perspective is really important, so that people feel that they belong. I think that's a really important point for us. And I don't know what my third one would be. Yolanda might help me out here, but I think it may be something to do with one of our biggest pressures at the moment is recruitment, and it's supporting the divisions and all the divisions in the infrastructure and the background to make sure that we can reach the parts that traditional methods might not use. And my last point on my commentary was something that we're doing a bit differently. But I don't know, Yolanda, whether that aligns with what you would pick.
It's a jolly good job it does, John. I'm Yolanda Martin. I'm Associate Director of Communications. Yes, John, that does align with what the three things that I wrote down immediately were: patients are our priority. So we always try and get across the fact that patients are the top thing that we're here for, and anything that has a patient angle, that's the first one. The second thing I wrote down was quality, and that's how that relates to patients, and also the quality of experience for our colleagues. And the third one was trying to reflect that we're a great place to work and helping us with our recruitment. And linked with all of those is, John called it connection, but due to the NHS ID guidelines, organisations have to call themselves the geographical location in which they are based, and that means we're called Nottinghamshire Healthcare. So, for instance, we spend quite a bit of time trying to portray in our communications that we are regional and national. And we've got a recruitment campaign that's going on at the moment. John mentioned the Sherwood Oaks one and the campaign that we've got there, but we've also got one going ahead on social media. And there is a face-to-face event as well in Arnold Lodge in Leicester. And for us, we are turning our communications not quite on the head, but a little bit on the side, so that we are mentioning in all of the first lines of our adverts and things about Leicester that we are based in Leicester, trying to recruit people there. So yeah, it's good to see that John and I are both aligned. Reassuring.
Thanks, Yolanda. Paddy, hopefully that gave you some sense. Do you want to just come back?
I thought it was a really helpful answer, and given the negativity that's around the NHS from some people, that positive story I think is really important. And Yolanda will recognise the old phrase, tell them again. And it's important that we have consistent messaging around the headline themes.
Great, thanks, Paddy. And Yolanda, I had seen the Arnold Lodge advertising and thought that was a really, really good development. Okay, I'm not seeing any other hands going up. John, just as a final piece around the Care Quality Commission being with us, I did just want to, it's always dangerous to do, but I did just want to name check a couple of people. I think the CQC themselves, actually, when they gave us high level feedback, they particularly mentioned the support they'd got from Grace Rowe and from Kira Lever, logistics support on the ground during the Well Led. And I just really wanted to acknowledge for both Kira and Grace, their job was basically not to be noticed for everything and everything just to get done. And I know that they worked really, really hard at that, which was great. And also just to acknowledge that we had some superb specialist leadership over many, many months now from Sharon Rosenfeld, who has really helped us understand quality improvement whilst also holding a lens of the CQC. And finally, just to thank Anne-Maria for her executive responsibility around this, particularly over the well-led. It helped us, I think, do the very best that we could with it, which is great. So let's move on then to the integrated performance report. Just before I go into this, Alison, I was just going to flag for anybody who's got papers with them that there is towards the end of our papers today, there is a glossary of acronyms, and I know some do sneak in. I know we had the ICS, the Integrated Care System, and ICB, Integrated Care Board, and we do genuinely do our best not to baffle with acronyms, but just to flag that there is a very fulsome glossary towards the end of our papers today. But let me hand across to you, Alison, to steer us through this, please.
Thank you, Paul. Alison Wild, currently Interim Executive Director of Finance and Estates, soon to be substantive in my role. So I'd like to take you through the Integrated Performance Report for the period 12, so the end of March 2022. The report is for assurance and it details performance against our regulatory standards and our internal targets. It highlights in the main areas of change and where we're below expected levels of performance. So I'll take it through in the order of the paper and hand over to Anne-Maria Newham for quality. Thank you.
Thank you, Alison. Yes, my name's Anne-Maria Newham, the Executive Director of Nursing HPs and Quality, and we're going to just take you through the quality elements of this integrated performance report. The first one to talk about is wards with safer staffing rates that are lower than 85%. Now, for the audience, just to say is that this is normally because we've had sickness, absence, we've not been able to fill the shifts that have been required. So when it drops below 85%, that's normally the reason why. So the number of trust wards that have been experiencing significantly low staffing has remained above upper control limits. And I did report this for the last couple of months as well. And that's for 8 successive months now, with month 12, which is March, reporting 21 wards with staffing levels below 85%. And again, that is the highest figure for 24 months. And as previously, this tends to be affecting the forensic division, particularly at Rampton and Arnold Lodge medium secure unit, which we've just been talking about, which is actually in Leicester. The next area is around COVID, and I'm glad to say that the level of patient cases are reducing and have reduced. So we had in February, we did see a spike because of the Omicron variant around December, January into very early February. So we had 64 cases in February and we're down to 50 cases then in March. So that is a definite downward trend of cases. And I can also say to you is that I've not reported any outbreaks for the last 2 weeks as well. The third area is around hate crime, and actually I'm not going to say anything about that because it's a repeat really of how it's been going for the last 2 or 3 months on hate crime, and there's nothing new for me to say to the board on that area.
Thanks, Anne-Maria. Let's just pause to see if we've got any questions or comments. I've got one if nobody else has, but I'll wait for others to indicate if they want to flag anything. Anne-Maria, I just wanted to make the link there around the staffing. Yeah. You talked about our control levels and the fact that we've now had a significant number of months when the numbers have been off, and it was just to make the connection that tells me that we need to do something different. Yeah. And I think that some of the recruitment pieces that we were hearing about earlier, and also the international recruitment, are a couple of examples of that. So let's see. I've got Nigel and then Manjit. Nigel, please.
Thank you, Chair. Nigel Smith, Non-Executive Director. Anne-Marie, I can't let it go without coming back to my compliance upheld percentage figure that you commented on before. I'm going to be hard to please actually, because I am quite disappointed the percentage has gone down. I rather hoped it would go up, because I'm taking it as an indirect indicator of how receptive we are to patient or customer complaints, and my starting point is always the customer is right. So just a comment really to say that actually I'm looking for a high number there, not a low one. My question, Anne-Marie, if you don't mind, is on the hate crime number of incidents that you didn't comment on. You said that we'd already discussed it. I still can't be comfortable with the level that we're getting, and I think the missing piece for me is if we're not going to have a zero tolerance approach to these incidents, what exactly is our policy when such incidents get reported, and what criteria do we use to decide whether or not to take anything further?
Can I just mention around the I'm a little bit confused by the partial and upheld. In my world, and I've done 40 years this year, going down is good. So maybe we'll have a conversation outside from Nigel just to help us to understand why you think it would be good for partial and upheld complaints to go up. So let's have a conversation about that, because that's really good in my world. With regards to the hate crime, I think that the increase for me is really good on hate crime, because it shows that there's a confidence from staff to be able to report it. Now, we are encouraging staff to report, and we did have much lower levels, and you could see that big shift. And we are encouraging people to report, and everything is taken seriously, so we don't sort of like minimise anybody's experience. So I think that from my perspective is that we have seen an increase. That is positive. Staff are aware that they can report. It's much easier to report. We've got a really good sort of like reporting mechanism. We've got the reporting toolkit that we use as well. We've put a lot of training in. So we commissioned Communities Inc. to deliver training to help staff understand, number one, what hate crime is, because sometimes people put up with it and don't realise that it is. That's what it actually is. But also Communities Inc. have helping staff to respond in a really appropriate way as well. So I think that all of these combined together are making it a much better position for us. But also we're saying to everybody, you know, we won't tolerate that. We will not accept that. With regards to zero tolerance, I absolutely agree with you. And I think that from my perspective, I've called a meeting together with all the interested parties, including Manjit and our Equality and Diversity lead and our HR partners. So I've called a meeting together just to say, how are we going to actually represent that to the outside world, to the police, to the Crown Prosecution Service, to what we put on our intranet and internet sites as well. So I've called a meeting which will be in the next couple of weeks, just to say what are we actually saying and what are we doing with regards to zero tolerance.
Nigel, do you want to just come back?
Thanks, Paul. Thanks, Anne-Marie. I think we're on the same page then from your last couple of comments there. I would like to hear or see the outcome of that discussion in terms of what we're actually going to do and what we say to staff in those circumstances. I think will be really helpful, but thank you. Great,
let's go to Manjit, please.
Yeah, thank you. Manjit Darby, Non-Exec Director. I think just following on from Nigel's comment, one of the things I was going to say was that when we started getting reporting figures on hate crimes, we were told that actually the percentages are going up because actually people are becoming aware of the reporting process. So there is a point at which we say, well, actually, how long do we have it going up? And then when do we see action to bring it down? So I absolutely support Nigel's point on that. And I think that the meeting you called is a really important one. So thank you for that. I just wanted to go back to Paul's point about the say for staffing levels dipping below 85%. And when we look at page 34, we see that it was kind of breached its tolerance level for quite a long time now. And I'm just, you know, there's a massive kind of discussion to be had on whether we're going fast enough and far enough in terms of recruitment to address the underlying recruitment issues that we've got. But in terms of kind of what it means for patients and what it means for staff, managing staffing levels that fall consistently below 85%, I just wondered if you would comment on that, Anne-Marie, and kind of the messages that we give to staff and how we support staff and patients in this kind of environment, which feels slightly more chronic than kind of a something that is just, you know, a one-off.
Yeah, I agree with you. I think that to see it consistently now above that top red line, and that's the 9th now month that we've seen that as the below. There's a couple of bits. I think that patient experience will be affected, particularly if we aren't able to do as much activity, outdoor space activity. The only thing that is not included in here is the amount of redeployment that we did. So say, for example, if we moved people from, and that has happened, particularly in forensics, I know that's happened. A lot of people have been redeployed out of other activities, out of non-clinical activities into the clinical environment. So whilst those are the numbers that are saying that's the staffing levels, we have maintained safety and we've maintained a certain level of kind of like experience for the patients through redeployment and making sure that staff are moved around to cover wards and to make sure that there's enough staff there. So, but that's not reflected necessarily in those numbers, because those numbers are only the substantive staff that are aligned to that ward and establishment.
Should we just ask Jen if you just want to pick up some of that commentary about the recruitment side of things, Jen?
Yeah, so at the risk of repeating what Anne-Marie has touched on, I just thought it'd be useful coming in, obviously, because it's my area of lead responsibility. So we are trying to be innovative and do different things in order to attract and recruit staff. And it's also crucial, obviously, that we retain the people that we do attract. So in terms of attraction, you have seen we've got recruitment roadshows, going out into local communities to try and recruit people new to the NHS. We're learning as we go along, so we're on our 3rd now, and on Saturday I've just had some headline figures. We actually recruited 6 HCAs on the day, which is not something we've done before, so really making progress there. As Paul said, we're looking at more innovative social media and sort of digitalisation of advertisement, but also noting that there are publications out there that we can still use. So we've got a subscription for senior jobs with the HSJ. We're also working with the Civvy Street magazine to try and attract ex-forces personnel. So lots and lots of innovative things and new things happening. Big shout out to Yolanda's team for the graphics, because they're really, really catchy. So anyone who doesn't follow us on Twitter, Facebook, please do, because I'm sure your networks would help us in terms of getting those graphics out, because they are really eye-catching. We've got a bit of detail going to the People Committee as an appendix to the Exec Director Overview Report in May around detail around some of this. So there's not an item specifically on recruitment and attraction on the agenda, but we have woven in an appendix to one of the reports to give a bit more detailed assurance, because it feels like that's what's needed at this time, some of the detail.
Right, thanks. Manjit, does that help?
Yeah, no, that's really helpful. I mean, I think that there's a separate conversation about our response, but I'm really interested in making sure that we deal with the chronicity of impact for staff and for patients, and maybe we'll spend a bit more time in the People Committee looking at that.
Thanks. Fiona, let's come to you, please.
Thank you, Chair. I had, sorry, it's Fiona Daniel, Non-Executive Director. So I have 3 questions, one of which has been kind of answered, but just to reiterate, it was around the wards and safer staffing. And it was really just to make sure that we do take the opportunity to review the assurances that are in place. We have had this steady now progression or stability of 8 months. So I think it's really time for us to really check through that the assurances that we have in place are working, not working. I'm just listening to what Jennifer's just said, so there's some great things going on, and I think obviously we need to reflect that in the detail now. So that was the first thing. The second one was around, so I've read a couple of times now in each of the boards, the situation around hate crime, particularly with repeat offenders. So my question is particularly around the psychological safety and the exposure to staff with these repeat offenders. What do we have in place to make sure that they are not constantly exposed to receiving, being on the receiving end? And then the second, or my last question, is around, there's a bit in there around pockets of underreporting. So I just want to understand what is giving us the sense that there is this pockets of underreporting, and what can we do to increase that? Thank you. Thanks, Anna Maria.
Yeah, no problem, Fiona. So with regards to the wards and safer staffing, I know that you did say that it had been partially answered, but around the assurances, I think it is a really good conversation for us to have at the People and Culture Committee, if that's okay.
Yeah.
And I do agree with you. I think that the consistency above the level of assurances that we now need to start giving are really different. So, I welcome that as a conversation. I do need to include my 3 kind of like ops directors in this conversation, because whilst what I'm doing is that I'm presenting what the establishment is and what the reduction below the establishment actually is. So that's what I'm presenting. But with regards to like, how do we tackle that and how do we bring it up so that it's above the 85%? I think, I'm very looking towards sort of like my ops directors and HR to help me with that conversation. With regards to the second one, which is around hate crime and the repeat offenders, I mean, that's a really interesting one, because what we are doing is we do recognise there are repeat offenders, so you're absolutely right. We do recognise there are, and the amount of work that is needed to go with that individual is quite a bit, and sometimes it's about escalating it up to the police. Sometimes it's about escalating it through into their case holder, their coordinator, to actually really look at what is driving that behaviour. So there's a lot of work that looks at behaviours, and that's some of the things that Communities Inc. have helped us with, to help staff to understand what is initiating it. How do you sort of like much more on the prevention side, rather than sort of like allowing it to happen and then reporting it and saying it's something wrong. So that is the big piece of work that we're currently doing at the moment. And again, that's a lot. I'd look towards my kind of like quality and diversity leads, because we've got those in each of the divisions at the moment. And Catherine Contra, who's our quality and diversity lead for the trust. But I know that Maxine has been doing a lot of work within the mental health division, and Robbie's been doing a lot of work within the forensic division to do exactly this. Who are the repeat offenders? What work can we do with them? The other thing that we found, and this was really good, because I found this with another trust that we did, is that they have a police actually on site.
Yeah.
Say, for example, within the mental health unit, they've got a policeman on site, and they often help us with kind of like tackling that behaviour, to say no, that's not acceptable, we won't have that. And then also the psychological safety. Yes, you're absolutely right. There's a huge piece of work around psychological safety. There's a lot of both awareness, training, helping staff, post-incident debriefing. There's a really good setup around the post-incident work. And that's also done when it happens with regards to some restrictive practice that's occurred as well. So we don't just do it for this, we also do it around restrictive practice as well. And then the pockets of underreporting, I think, it's an interesting one. I think wherever I've worked, you will always get little pockets of people who have not necessarily either recognised it or think it's normal. And I think that for us is about how do we extend really our kind of influence into all of those areas to say no, that's not acceptable. We won't, you know, we want to help you, let's work with you on that. So I think that's just that for us is work in progress, and that's what we need to continue to sort of like tackle. I hope has that answered your questions. I hope so.
It has. Thank you.
Thanks, Fiona.
Thanks, Paul.
Okay, thanks. Just as a final thing, Anne-Maria, just to follow up on something that Manjit had picked out, on the hate incidents, I think that graph is now showing us that, broadly speaking, we now know what the reporting level should be. We've got 8 months. If you draw a line through that, that's basically telling us we're at about that is the reality now, whereas a few months before then we were clearly underreporting. The challenge that, as Manjit said, was that we now need to see that coming down, and I think that's a useful one for us. But it's just to clock that. Okay, what I suggest is that we get into the people section with a view to taking a comfort break after that, if we can. Alison, please.
Thank you, Chair. Alison Wild, Interim Executive Director of Finance and Estates. I'm going to hand over for the People and Culture overview now to Jen Guyver. Thank you.
Good morning, and apologies I didn't introduce myself before when I came in to answer that question. So Jen Guyver, Deputy Director of People and Culture, and I'll be starting as Exec Director in the not too distant future. So it's clear to see that our people stats, or some of our people stats, are really not where we'd like them to be. And I guess when I'm coming into my new role, I know that they're the areas we need to prioritise in terms of metrics. So just to take that note, then I was just going to highlight 3 areas. One, our sickness absence level. So you can see from the IPR that we saw another, quite small, but another increase between February and March. We're just finalising or validating the April figures. It does look like it's slightly come back down again to 7% or just below. But in March, which is what we're looking at today, we were at 7.4%. We are receiving a deep dive into absence levels at the People Committee in May. So that's around what we're going to do operationally around absence, but this obviously also links to prevention as well. So we've got a new staff wellbeing lead in post now, and there'll be a plan around our wellbeing approach coming to the July People Committee as well. I have done some benchmarking over the last few days with peer trusts, so large mental health and community trusts, and we are the graph around sickness absolutely follows the peer line. So although that's not a position where we don't want to be at 7.4% staff sickness, we are in line with our peer group. Moving on to turnover, this was flagged at last board. And we were at 14.2% voluntary turnover in February, slightly risen in March to 14.5%. Around that metric, we're refreshing our exit interview process. So there's a rich wealth of data there from people who've either chosen to leave or have left. And if we can act on some of that feedback, hopefully before they actually leave us, or if not afterwards, that would potentially help our turnover figures. I think there's a big link there to leadership. So people stay because they have supportive managers, and we need to look at leadership development in this coming year. And then finally, appraisals dipped slightly in March, which I think again is due to COVID staffing pressures. We're still a solid performance, really just below the 80% mark, but that's obviously something we need to prioritise because it's important that all our staff get a quality appraisal once a year, but as an ongoing process throughout the year.
Thanks for that, Jen, and also just to clock your opening comment about there being a number of metrics that obviously are not where you'd want them to be, that we haven't got this level of detail on for this board meeting. Sue Nixon, please.
Thank you very much. Sue Nixon, Non-Exec Director. Hi, Jen. Congratulations also in terms of your new post. However, I would like to just pick you up on a couple of things, if I may, just to get a bit more colour to some of the points that you've just made, please. In terms of this commentary on the sickness deep dive, it's probably a bit unfair given that we're going to have the outcome of your deep dive at committee in just over a couple of weeks' time. But presumably the deep dive has been done, and you've said that this will inform plans to respond to the high level of sickness. How confident do you think the response and the plans that you're going to be sharing with us or coming forward about the deep dive will actually help resolve some of the sickness issues?
So referring back to what I touched on just before, I think there's two ways, or there's many ways, but there's two broad ways to respond to a high sickness level. One around attendance management, so supporting people to be at work using our policies, and that operational attendance management is what that deep dive is focusing on for the people committee, because that was the ask. So around where are our areas of concern, what are we going to do about it? And to some extent that is a reactive piece of work, because the people are already off sick or the percentages are already high in terms of short-term sickness. That has to be complemented with a preventative agenda, so our staff health and wellbeing plans. So in terms of confidence, I believe that if we can support managers who are suffering the highest levels of absence in terms of operationally managing with our occupational health team, so getting people back to work or keeping people at work, plus we complement that with the preventative agenda in terms of the health and wellbeing and also the access to support. So when things are going wrong, we don't get into crisis point that people have to have time off, that they can get support prior to that. I'm relatively confident that that will help us with our metric. I think the issue with attendance is that there are lots of variables, so leadership, staff engagement, and also external variables like COVID, for example. So levels of confidence have to reflect that myriad of variables, really.
Sounds like plenty more, Sue, for the committee when you get to the deep dive.
I think so, Chair, particularly as Jen has interestingly done a split in the body of the report in terms of those absences that are COVID related versus those that are not, and it's getting to understand that detail. So I think I'm eagerly looking forward to our debate for the assurance information there. Thank you.
Thanks. We'll go to Nigel and then Carolyn, please. Nigel. You're on mute, Nigel, I'm afraid.
Thanks, Paul. Nigel Smith, Non-Executive Director. Not really questions, Jen, so I don't think I need a response, but just observations to take into account in your further work on these things. On the sickness absence, just to follow up what Sue was asking. The interesting thing for me on the graph on page 39 is that if you exclude the COVID-related sickness and the infection precaution and shielding, the yellow bars are still trending upwards. If you did a 12-month rolling average, put a line through that, it's an upward gradient, and that for me is the most worrying feature of the chart. But I suspect that it's not quite as easy as the chart suggests to separate out the COVID and the non-COVID, and there might be a bit of ambiguity in how that's being recorded. So I think we need to get to the bottom of that. If it's trending upwards, excluding COVID, I think we should start to be worried about it at this stage. But the numbers this March compared to last March and this February compared to last February are up, and that's a worry to me. The other observation, which I know we'll come back to later on, we've got a separate agenda item on, is staff survey, which I must admit I was surprised to see as a positive performance highlight, because I didn't see the staff survey results as a positive performance, and I think there is plenty to worry about in there, which no doubt we'll come back to later. So my observation is there is plenty of good things going on in the HR field, and plenty of good things that our staff are doing that we could find to populate that section. I know the overall metrics that we've already pointed out, there's lots of red, but there are lots of good things in the HR area that we could highlight. And I wouldn't personally have picked out the staff survey as one of them.
Let's come back to the staff survey when we get to that item in terms of detail, Jen. Carolyn, do you want to come in? And then I think we'll try and wrap this piece up. Carolyn.
Yeah, thanks, Chair. Carolyn White, Non-Exec Director. Jen, I asked this question last month and I'm going to ask it again because I think we need greater clarity on the COVID testing. So the numbers that are the whole numbers that are reporting 427,549 gives us no context. I'm assuming that's a running total because last month it was around the 376,000. So the real question is, what is our expectation? That gives us around 50,000 in the month. Is that good? Is it bad? I know there's a concern that people are not recording them but are doing them, but I suppose what I'm seeking assurance is that we've got a really tight grip on this across the trust as we're coming hopefully out of this latest peak.
Okay, so I will look at how we can better present that data, because it would be better present as a percentage of uptake, for want of a better word, or compliance. Yeah. And so we'll do that ready for next month. And secondly, yeah, our IT team are really good at producing dashboards, and we have dashboards, is that right? So applications essentially to help us manage things internally, and we've got a really good testing app. That you get a reminder if you haven't submitted 2 tests a week. If you breach the date, you'll probably know yourselves, you get a reminder. It's really simple, you can do it on your iPhone. So in terms of assurance that we have a system in place for assurance, yeah, we absolutely do. And thanks to our IT colleagues for sorting that out. But we can present that data a bit better for you, so we'll do that next month.
Yeah, and it would be interesting. I mean, you may already be looking at this as an exec team. If there are pockets of staff who are not, and that correlates with high levels of sickness absence, for example. Thank you.
Thanks, Carolyn. And Anne-Maria, do you just want to comment on that last point about the testing piece?
Yeah, so it was just to say that we have really struggled from the very, very beginning when we were allowed to start testing and doing lateral flow testing twice a week. We have really struggled with getting our percentages up, but we have done a bit of a benchmarking across with our other colleagues across all different trusts, and they're all averaging at a similar level. We've tried to make it a lot easier as well. So we have an app, we have the Connect, we have lots of different ways people can put their results in. We are more confident that people are actually testing. We're not so confident that people are recording. And it was just to say that whenever there's an outbreak, what we do is ensure that people are testing twice, before they come on shift. So every member of staff that walks onto that ward is tested pre their shift. So that occurs for the whole of that outbreak, which is often up to sort of like 14 to 20 days. So we are confident in any outbreak areas that staff are testing because they have to do it before they come on shift as well. So I agree with Carolyn, it's not been great and we have struggled, and the 29% is pretty much average of what we've been achieving throughout. We've sent so many messages. It feels a little bit like, you know, how do you get people to exercise? How do you get people to diet? How do you get people to give up smoking? It feels in that bracket of how do you get people to change behaviours. It's been a very, very difficult journey for us.
Thanks, Anne-Maria. That's helpful context as well. So, Jen, I think we're all on a similar page on many of these issues, and we'll come back to the staff survey piece a bit later on for a bit more exploration. OK, folks, let's take ourselves a break. Can we restart at about 5 past, please? Or do you want slightly longer? Should we say 10 past? 10 past, let's have a proper comfort break. Restart at 10 past 11, please. Thanks very much. Okay, let's resume if we can, please. And Alison, if we can go back to you for your next piece of steer, please. Alison.
Thank you, Chair. Alison Wild, Executive Director of Finance and Estates for the Trust. We're currently on the Integrated Performance Report for month 12, and we are moving on to the performance of the operational divisions, starting with mental health. So I'll hand over to Chris Ashwell. Thank you.
Thank you. Good morning, everyone. Chris Ashwell, Deputy Director of Local Mental Health Services, Notts Healthcare Trust. So I'd like to just point out a couple of performance measures where we've done particularly well, and then a couple with some room for improvement. So starting with the physical healthcare checks for mental health inpatients, we've achieved 85% on this target, which is really satisfying because it's well documented the poor outcomes for people with serious mental illness with physical health. So we're particularly pleased with that target, achieving that. In terms of improving access for psychological therapies, our recovery rate is at 56%, which again, it's really good. It bucks the trend nationally. Quite a lot of services below 50%, below the target. On the downside of that service actually is the recovery rate for the BAME recovery rate, Black and minority ethnic groups, which is at 47.6. So that's just below the target. There is a recovery action plan in place, which is quite detailed actually. Service doing quite a lot of work on that, and that goes to the Mental Health Legislative Committee in June for consideration. Also on the downside, despite our best efforts for out of area placements, we were actually doing really well with this, and I think we were probably on target to meet 0 out of area placements by the end of March. Unfortunately, with the recent pressure on beds, we have seen increased demand and challenges in those services, and we've actually had to place some people actually just on the border actually of Nottinghamshire, but they are considered out of area, a place called Mill Lodge. So for the last month we did unfortunately have 68 days out of area placements. And another target where we've just failed to miss the mark, and again this is a safety target, so it's disappointing, is on the 72-hour follow-up from discharge from a mental health unit. We did think we'd got on top of this issue, that there were some data quality issues, which there still is, or there still are. But even so, even with data quality, we would have only been at 78% for this last month, which is disappointed given the safety implications. So reasons for not meeting that target are some people just don't engage, which is difficult to overcome, but that's why there's a headroom and the target actually, but not actually registering the discharge from an inpatient facility for the community team to follow up, and carrying out the follow-up too early, so before the 24-hour period. So they're areas that we can improve on and should do, and hopeful for next month that'll be back on target, because for so long actually we were comfortably meeting this safety target, and it is disappointing. So they're the areas that I'd like to point out, if there are any questions or comments.
Thanks, Chris. We'll go to Nigel and then Paddy, please. Nigel.
Thanks, Paul. Hello, Chris. Nigel Smith, Non-Executive Director. It's about the out-of-area bed days. I'm just trying to test my understanding of what's going on. This 0 target ambition, I think probably it's never going to be possible to achieve 0 consistently. So as long as it's low, I'm taking that as a good sign. So 68 days is a pretty good achievement actually in context. But what I'm just want to try and understand is the graph that's next to it. we've got 1,670 non-NHT bed days. Are those 1,670 days with another provider in Nottinghamshire, or are they out of area as well?
Yeah, that's right. So we have a number of subcontract beds within Nottinghamshire, some contracted to the Priory, so they are considered appropriate. So whilst they're not Notts Healthcare beds, we do have what we call continuity of care principles agreed with those services, which basically means that the patients are getting the same level of quality, follow-up, connection with the community, recording, etc., that they would in a Notts Healthcare bed.
Are they in Nottinghamshire though?
Yes. They're in Calverton, one in Nottingham, and one sort of on the borders of Mansfield, but they're all in Nottinghamshire. Yeah.
Okay, thank you.
And Paddy?
Well, Chris, thanks. Can I just follow up Nigel's point, Paddy Tipping, Non-Executive Director? Just talk to me a bit more about the Bassett Law situation, because my recollection is that this isn't a new issue in Bassett Law. It's been running for a while. Just talk us through a bit more about that.
Well, Bassett Law beds are considered in area. So if there is a patient in a Mansfield or Nottingham bed, that is considered in area. And in fact, we do have patients from Mansfield or Nottingham in Bassett Law beds, and that's related to flow. Really, it's not always easy to direct people into the most local bed because, you know, when you've got serious bed pressures. So there's that, but then we do occasionally have to send people from Bassett Law, which of course is in Nottinghamshire, out of area. Their numbers have always been relatively low, actually, in comparison. But yeah, I think there were 7, was it last month? So yeah, it's unfortunate, and we're hoping when we have Sherwood Oaks fully up and running that you know, we'll be able to manage this issue much better.
Okay, that's fine.
Of course, we do have in Bassett Law as well, they are dormitory beds, so we have to close some of the beds down because of IPC cohorting, because of COVID reasons. So we don't have quite the capacity there that we would ordinarily.
So just remind me when Sherwood Oaks is going to open?
I think we're hoping around sort of October, November to have patients in there.
Thanks, Paddy. And Chris, it's worth saying the out of area bit is linked to kind of county boundaries, isn't it? So you could have somebody who's actually placed very near their home but in another county that technically is scored as out of area, whereas you could also then have somebody who's on the other side of the county who's technically in county but has a real is quite a long way from their home. And yeah, I think it's worth us just remembering that context for what out of area actually means. Is that correct, Chris?
That is correct. Yeah, that's a good point, Paul. Yeah, the important thing, as I stressed earlier, is the continuity of care, that the people are getting the correct level and quality of care and ability to connect with their communities and their carers. The place Mill Lodge, where we have them, is actually, I think it has a Nottinghamshire CCG Derbyshire postcode, but it's in Leicester. You know, it's one of those sort of quirks where they sit in that peculiar position.
Great, thanks. Manjit, come in, please.
Thank you, Manjit Darby, Non-Exec Director. Just a couple of things. Firstly, just an acknowledgement of the physical health check achievement, Chris, because that's not easy to do in mental health. So just wanted to acknowledge that. Secondly, I just wanted to check the position in relation to kind of where staff are at in relation to the mental health division. Been on Opal 4, I think the report says, consistently throughout March. If Julie was here, I'm sure she'd make reference to staffing and some of the recruitment gaps that you've got at the moment, but they're not mentioned in the report. Just wondered kind of what the state of the workforce looked like in mental health and how much that was impacting on current position that you've got.
Yeah, we do have higher than trust average vacancies and absences in our inpatients, in particular the acute adult mental health wards. That's really challenging for us, in particular at the qualified level, the band sixes, and you know, with the trust initiatives we've tried, but that is proving difficult. But we're also seeing real pinch points at the front end in some of the other services. So we have high levels of absence in our crisis teams in City and County South, and we also have high absences in particular in the City local mental health teams. So it has a compounding effect really on the whole flow. And I think that's one of the reasons we're seeing the demand on beds actually, is the challenges we're seeing in the community and crisis team. So yeah, we are trying to do what we can. Of course, you know, we use agency, which is not ideal, and would really like to reduce that. Last week we had the first week in our CAMS Tier 4 service actually with no use of agency on 2 or 3 days, which was particularly pleasing. I think that was more about managing admissions, so we had a few patients which we struggled to do in acute mental health in particular, but it is a real challenge for us.
Yeah, thank you. I mean, I think that I just wanted to make the link between, because the flow issue isn't just related to a lack of beds, is it? There is a real workforce connection. Absolutely. And you know, and again in the people committee, I'm sure that we'll spend a bit of time thinking about what that actually looks like and what it means for staff and patients. Thank you.
Thanks. In that case, Alison, let's go back to you to steer us on. Thanks, Chris.
Thank you. Alison Wild, Interim Executive Director of Finance and Estates. So we're staying with the operational divisions and we'll move over to Community Health Services and Becky Sutton. Thank you.
Thank you, Alison. So I'm Becky Sutton, Director for Community Health Services, and just to highlight a couple of things on this month's IPR, very similar data that we report most months. I am, Chair, going to leave out some of the weights because we've got a paper preceding this item and I don't want to, for fear of repeating myself, that's a little bit wider in terms of all the weights across community, but they're slightly different time frames. So I'm just going to highlight on 2 areas this morning. So we continue to increase and expand our urgent community response teams and capacity, and really delighted to report this month again we're seeing 95% of patients within 2 hours of them being referred for their response, and you will see in terms of volumes those numbers are going up steadily. So 243 patients were seen within March, and they are, as I've reported before at board, patients who, if we didn't go out and see within the community, would be seen probably in an ambulance at our ED department. So again, a really important service to try and keep people at home and keep them safe. The national target for that is 70%, so we're doing a really grand job in terms of that performance target. The second of those 2 targets is how many patients we can provide reablement within 2 days, and again achieving 98% of patients within 2 days, and again a steady increase of patients on that service. The other area I just wanted to talk about was Lingsbar Hospital, which we heard a little bit about this morning, but we have seen the length of stay of patients within that rehabilitation unit increase from our target of 28 days to 34 days. There has been a deep dive undertaken to all of the length of stays at Lingsbar, and predominantly, as we thought, most of those delays are as a direct increase of handing over patients to our social care teams and delays in home care because of the huge national shortage of home care workers. So there's those waits and length of stays, we're assured, are a direct result of patients that need home care placements and treatment. There's an awful lot of work going on across the system to try and help with that and work with social care to provide more home care provision, of which we, as you will know, have increased our capacity in there in terms of the things we can do with community. So really, you know, that length of stay will stay where it is until we see a good recruitment into the healthcare workers. And that's probably all, Paul, because Chair, sorry, because the rest of them are around weights, which I'll talk about when I come onto the paper later.
Yep. So our next item is on the weights, so we'll hold those. I'll just pause to see if anybody wants to pick anything else up. I'm not seeing any, so let's move on, please, Alison.
Thank you, Chair. Alison Wild, Interim Exec Director of Finance and Estates. Moving on to our final operational division, I'll hand you over to Sue Elcock for our Forensic Division. Thank you.
Thanks, Alison. So Sue Elcock, Director of Forensic Services. A little bit like Becky's position for community services, this is very similar picture month on month in terms of the forensic division. As we've talked about already, the thing that I'm most worried about is both our staffing availability, our staffing recruitment and retention, but also our staff wellbeing, as colleagues have already talked about. So I won't labour the point, but I did need to highlight that those are the three areas we're most worried about. In terms of one positive, trying to find something, because there is some positives. You'll be aware that when I've been at board before, we've talked about January being a particularly sort of pinch point for us in 2022, and these figures obviously talk to March, where you can see there are 0 lone working shifts, which actually in the whole scheme of what I've been presenting to board over the last particularly 6 months, I would say, is quite a shift forwards. I'm mindful that Adele presented our sort of impact weighting paper last month at board, but as I know was highlighted there, we are looking at the triangulation around our staffing levels, and I think Anne-Maria was asked a question about impact, but you know, in terms of activity, but also in terms of our incidents, our complaints, SIs, things like that, to make sure that there's you know, there's nothing that we're missing in terms of that so what question that colleagues have asked before. In terms of bed occupancy, this is always talked about in the IPR about forensic services, and we're starting to think about what else is important for board to understand about, and that was that part about flow last week, last month. So for us, one of our strategic objectives is looking at our care pathways across certain elements of our secure estate to see if they're fit for purpose, looking at the patient population and demand moving forwards. And then the other thing that I know was talked about is, which we're monitoring but we won't know yet, and I think Becky talked about it in terms of Lings Bar, their length of stay is one of the impacts for us going to be about length of stay being impacted on, rather than the front end weights and recovery weights. Is our recovery going to be about length of stay? So we're just very mindful of that. So I just wanted to bring that to board's attention. So I'll take questions.
Thanks, Sue. I think it's helpful you just pointing out that you're doing that, thinking about, is there a refresh of what actually comes to us to make it really meaningful for us as board. Nigel.
Thank you, Chair. It's not actually a question for Sue. I've waited until the end of the operational performance updates to ask it. It's because it's about collectively operational performance. In terms of our governance, there's a very clear match between the HR section in the performance report and the People and Culture Committee, and similarly on quality, the quality section of the dashboard and the Quality and Mental Health Ledger Committee. But I'm not sure in our governance structure that the operational performance sections really get any scrutiny at any of the committees, and I'm just wondering whether that's falling through the gaps. So it probably would be a question for Shirley if she was here, but could we give some more thought to, please, to where in our committee structure those things should be picked up?
I'm sure we can. I'll pause just to see if any of the directors want to come back on that and just say where they think it's going. Or shall we make a note of that and make sure that that gets picked up? Yeah, Sue's giving me a nod there. So I think, yeah, it's let's pick that up outside, Nigel, and make sure that we get a sense of that for our for next time if we can. So Alison, back to you then.
Thank you, Chair. And just to pick up on that last point of Nigel's, the integrated performance report gets reviewed at executive teams every month, but isn't currently going through a formal committee, so it's something we probably need to look at. Thank you. So in terms of the finance overview for month 12 and March 22. Our revenue position hit our target of break even. We were 117k surplus as at the year end. And that's after taking into account impairments, or before taking into account impairments for changes in valuation of our properties. So in terms of the revenue position, we were more or less on target. In terms of our agency spend is something that we need to focus on going forward. We did spend £13.1 million on agency in 21-22, and that was £1.6 million higher than plan. And that was due to the staff absences and the need to recruit agency to cover safe staffing on our wards. So going forward, in terms of our functional improvement programme, we achieved 10.4 million against an £8.8 million target. However, only 40% of that was recurrent, so 4.2 million was achieved recurrently. Capital, we actually slightly overspent against our plan of 798,000. This was funded through external funding of NHSEI in terms of our IT equipment for late funding that was received in year. So overall, a pleasing position for the year end, hit targets on revenue, capital and FIP, but more work to do on agency. Thank you.
Thanks very much, Alison. Stephen, start us off, please.
Stephen Jackson, Non-Executive Director. Thank you, Chair. And again, formal congratulations to you, Alison, on your new appointment. It's well deserved. Thank you.
Thank you.
If you'll indulge me, I've got one comment and one question. The comment is that again, once again, we've seemed to manage to achieve our target, and to my certain knowledge, that's a 6th year running. So an excellent performance, and I think the whole executive team, supported by the finance department, should be congratulated on achieving such a fine result in not only difficult economic circumstances, but also with a great deal of uncertainty in terms of how the NHS finances were working. So I know that that's been a challenge, and I think you've all done extraordinarily well. In terms of the capital, I just wondered if you could provide a little more clarity, Alison. In the end, and despite the question I probably asked at every single board meeting is, are you going to achieve your spend target? And you have. So again, it's a good achievement. But it's the way that that's been achieved, in that there is an overspend in total, and then when you look at the detail, we've got underspends on some major projects. Probably one is to do with Sherwood Oaks, and then overspends in other areas. What's the impact of those over and underspends in the individual areas in terms of future years? Are we able to carry our allocation forward, or are we going to have to make adjustments in our budgets and plans?
Thank you, Stephen. Really good questions. Just to point out probably my lack of I shouldn't have said overspend, I should have said overplan, because the overcommitment of 798,000 was actually funded through additional funds from an HSEI. So you're right, there are some large projects that were underspending this year. A lot of that was around the critical pathway for Sherwood Oaks and supply chain issues as well on top of that in capital. So there are underspends in those areas. What we did manage to do was pull forward some IT spend that was planned to be in next year into this year to compensate for that. So that money will be available next year to actually to fund issues that the underspending that we've got to carry forward. So they will offset each other. However, as a system, we've still not set our capital plan for next year, and we're still looking at resources within the ICS and what that our allocation might be as part of that. So I can't guarantee that next year we won't be overcommitted at this point, but I can assure you that everything was done to pull spend forward to offset that underspend in some of the schemes. Thank you.
Thanks, Alison. And then my last question is looking forward to next year on the revenue side. And as you pointed out, the targets were achieved, but you achieved it through a number of non-recurrent savings, and I wondered if you could say a word or two about, you know, the pressure that will have on next year's budget, and the steps that you're taking to you know, to mitigate that.
Yes, thank you, Stephen. So yes, you're right. The non-recurrent nature of our financial improvement programme this year will have an impact on next year. So in terms of the plan next year, we are currently needing to achieve £20 million, just over £20 million worth of financial improvement. However, the full year effect of this year's recurrent FIPs is 6 million. So we've currently got a £14 million gap, which we are treating as absolute priority, and we are now getting together and actually trying to put a programme together of what that FIP programme may look like, and that is my number one priority now, given it's now the first week in May. We need to actually, as an organisation, pull together and work through what those FIP programme might be, but I can't give you the assurance at this point that we've got those schemes drawn up at this point in time.
Okay, thanks, Alison. Thank you, Chair.
Thanks. And Nigel, you may be going on the same tangent there. It might be something different. Over to you.
Yeah, well, I was going on some of the same tangents, so I'll defer those questions, and Stephen's asked them for me. These results are subject to audit, of course. I've just got to make that point, haven't I, being an accountant, that we have to go through external audit, but it is a very good result, and congratulations to you and the finance team for landing this, Alison, on this sixpence. The question I've got really is I'm afraid, a very boring one for everybody else, but I've got to ask it about the impairments. I think in the NHS, minuses are good news. I'm used to them being bad news, but I think they're good news. So this impairment, 4.8 million, is this a good news impairment? What's happened? Because it's quite a big number.
Yeah, it is about the change of valuation in property, and it is good news in terms of our asset valuations. We went through an exercise on the 31st of December where we revalued all of our assets, so that's an increase in the valuation of our assets.
Okay, thank you.
All right. So thanks very much, Alison, for that steer through. Oh, I'm sorry, apologies, Manjit. You'd like to ask a question.
Sorry, if I may, Manjit Darby, Non-Exec Director. Can I just go back to the FIP question, Alison, that you covered with Stephen? I'm just wondering about what the timetable for nailing that looks like, because you said that we've got a 20 million FIP to deliver this year. We don't have a we know what the methodology is going to be, and we've seen that in Finance Committee. Can you just tell us what the timetable looks like for nailing it, and also the issue of kind of the quality impact assessments of understanding that are going to take some time given the size of it, and also kind of how we're going to address the issue of non-recurrent nature of kind of delivery to date, because you know, how long can we carry on a non-recurrent basis without it really impacting on our ability to deliver financial balance in the future?
Okay, thank you, Manjit. Some really good questions there. So in terms of the non-recurrent nature of the FIPs, I think there's always going to be an element of non-recurrent FIPs in our accounts. My aim is to get a sustainable underlying position in the next 3 years, and I think we need to start thinking more medium term rather than in year, and I think we will get greater gain from that. So that's the first point. In terms of timescales, as I said, this is my #1 priority. Myself and Jan and the team and Fiona from Quality getting together as priority this week to set that timescale out and what that will look like. So it is #1 priority, and I'm hoping to get a plan. Well, there will be a plan to F&P committee at the end of this month in terms of where our large areas are that we're going to start looking at, what that might look like, and putting values to that. I don't think at that point we will have plans drawn up, but we will be able to give some assurance on the scale of things that we are looking at and the timescales. But I think there will always be an element of non-recurrent delivery, which is going to hold us up. And I think that's the nature of some of the large transformation schemes that we need to do now. I think we've got rid of a lot of the low-hanging fruit. I think there's still more we can do in terms of efficiencies, but I think the major things that we need to review as a board will mean that the lead-in time is longer.
Manch, does that help?
Yes, thank you. I just feel like we've got to be really clear about what the timetable looks like on this, because there's such a massive amount of work to do. But thank you, Alison.
And that should come to F&P at the end of this month, Manjit.
I think you flagged a question that you'll keep on asking until there's a clear answer there, Manjit. So it's one of those ones, Alison. So that's the end of that item. Just to clock that in that last piece there, I think there are some bits and pieces to ask the execs to reflect on around the governance elements, and our governance should always be movable to make sure that we're using that governance resource to the best way we can. For my money, it's not about us just adding more. It's about us thinking how we best use the governance that we've got, and it may be that we need to ask you to do a wee bit more on that. But thanks very much for the steer through, Alison. Let's move on, if we can, to item 11, Community Health Services waiting time position. And Becky, you flagged this during the performance report.
Thank you, Paul. So yeah, I'm Becky Sutton, Director for Community Health Services, and flagged this during the IPR report. So this is the third in a number of series of waiting list papers. I think last month forensic colleagues showed theirs, and the month before mental health. So this paper outlined the weights that we have within community services, and it's a paper for assurance. Obviously, the context of this is during the COVID pandemic, the last few years, we've had to put a number of derogations into services, which often have moved resources from some of our planned care treatments into our urgent care. And many of you will have heard me talk on a number of occasions around community health and moving resources to support discharges out of hospital to keep people at home on an urgent care pathway. Obviously, the impact of that is that we have seen a higher wait for some of our services, but within the report you will see and hopefully be assured that there are a number of our services that we still see patients in a very timely manner. There's a context here as well, so I think it's important to identify that routinely community health see 315,000 new referrals per year and an average of 26,000 a month for some of our planned care services. So when we look at some of the wait figures, whilst this paper is to be very open and transparent around where our weights are, they're very low numbers in the context of the number of patients that we get through our services. There's really only 3 areas of sort of hotspots that we routinely gain assurance from our units of management around trajectories, how we're going to recover some of the weights. And those 3 areas are paediatric surgery, again, which I regularly bring a report through the IPR report on, and the challenges within that service. That is a nationally reported 18-week wait, as we would call it, so a target of being seen and treated within 18 weeks for paediatric surgery. The second area is generically we would call it routine so therapy, so rehabilitation weights, and that's split into a number of areas, including weights for therapy, weights for some of our education courses in diabetes, which are called Desmond, and also some podiatry weights for our community podiatry services as well as neuro rehab in Bassett Law. What the paper identifies is some numbers. What I would like to say is this was a waiting list point in time at the end of Q3. So some of the figures that you'll have seen in the IPR report don't quite match up in terms of volumes, because this is always a moment in time. And the paper also outlines a number of actions that we're taking in those 3 services to reduce the waits for patients in all 3, really. I am confident to say that we have a very good handle over the patients in these waiting in the services. We routinely treat patients in a clinical need order rather than a waiting time order, and during the last 18 months done a number of exercises to triage patients on waiting lists routinely, which means going through the waiting lists, reassessing their needs and ensuring that we see patients with the greatest need first within those services. The other thing we do routinely is to encourage patients and write to them to let them know how long they might be waiting for services, alternative pathways, and also where to escalate if their clinical symptoms become worse and they need to access our services. So without going into lots of detail, that's probably all I wanted to say. Take the paper as read, and really happy to take any questions from any members of the board. Thank you, Chair.
Thanks very much, Becky. So let's open it up and see if we've got any comments or questions. I think it is helpful just getting that broader context, and also the just the flag about some of the numbers are small, which obviously we know that patient experience for those people isn't what we'd want, and it's that broader context that we're working in. So let me just see, Nigel.
Yeah, thanks, Paul. It's just a comment, really. I got a lot of assurance from this paper, actually, very clearly presented, and I'm not minimising for a second the impact of long wait on patients, but I got the sense from the paper that the numbers were relatively small, and that there was a process to monitor, manage and control this. So that's giving me the assurance, Paul, that I needed. Thank you, Becky.
Thank you, Nigel.
Great. Thanks, Nigel. And it's good just drawing that attention around actually the paper doing what we ask of it in terms of that assurance piece. So I'm not seeing any other comments or questions coming through, Becky. So I think that's a job well done on that paper. So let's move on then to the National Staff Survey. And again, something that we referenced a little earlier on. Jen, over to you, please.
There we go, off mute. So Jen Greiver, Deputy Director of People and Culture. So board previously received the results of the 2021 staff survey, which ran at the end of last year at the April meeting. So I'm not going to rehearse the results in detail, but just as a reminder, whilst our response rate improved and is above average to our peers, and we're around average for the domains that were measured against now under the new themes, and there's still a lot of work to do on staff survey. So we really need to work hard on staff engagement over the next 12 months and beyond if we really want to be a great place to work in line with the strategy. The report details the work we've done to engage with staff on the results since they were the embargo was lifted at the end of March. I think there is more work to be done, and we discussed the end of last week at a board development session around how do we hear the opinions of the people who don't complete the survey, and how do we engage with those people. So that's something for us to think about going forward. But for your assurance in terms of work we have done to engage with our plans going forward, John fronted a trust-wide event on the 4th of April that all staff had an invite to. It was actually really well attended, loads of innovative ideas, loads of interaction and engagement from the people on the call around what we could do to be better for our staff, so that's great. We engaged with our union colleagues at our Trust Staff Partnership Forum on the 14th of March. We engaged with the BME staff network end of April, and we also had the board development session at the end of last week. What those conversations so far have led us to conclude is that there's 4 areas that we'd like to concentrate on this year. And the detail of exactly what the actions around there are still being worked up. But those 4 areas, as outlined in the paper, are the quality of appraisals our staff receive, and crucially making sure that it's not just a once in a year conversation, that conversations around personal development, professional development are continuous for people who are employed at Notts Healthcare. Secondly, staff availability. I don't need to say anything more on that, that we've had lots of links. It's been the golden thread today really around staff availability. If people believe they've got enough colleagues around them to get the job that they want to get done and the quality of work that they aspire to deliver, staff engagement usually goes up. Staff wellbeing, and then just noting that we want to push that general staff engagement score. So I think in terms of an indicator of how we're doing as an employer, the question, would you recommend the trust as somewhere for your friends and family to work or receive care, is really crucial. So that's an area that the overarching plans will seek to make improvements on. I'll leave it there, Paul.
Thanks very much. Let's open it up. Manjit, please.
Yeah, thanks for that, Jen. Manjit Darby, Non-Exec Director. I think just reflecting on some of the discussions that we've had about the staff survey and our response in those 4 areas, I'm just interested in your thoughts about whether it's going to pick up the needs of the 1 in 4, the 1 in 4 that didn't answer just roughly didn't bother responding to the staff survey, the 1 in 4 that are saying, we're not prepared to recommend Notts Healthcare as a place to work, and the 1 in 4 that are saying, well, actually, I'm not sure that I'd want my loved ones to receive care here. So I'm just curious about whether focusing on those 4 areas is going to give us a response to those 1 in 4 areas, those 3, and then also, how will we know that we are doing what we need to do aside from waiting for the next staff survey and really buttoning down progress in a different way? Just your thoughts about that, please.
So in terms of the people whose opinions we haven't got, essentially, the 1 in 4 that you reference, I think we need to work up some more ideas around how we do engage with more of the population. So filling in a survey isn't for everyone. There's been some really good practice over the last couple of years. John's exec Q&A, the Connected Knots sessions, and I know they don't attract everyone, but the more you can do in terms of staff engagement, I think it's important that when we do staff engagement or we lead staff engagement interventions, there is the opportunity for 2-way feedback. It's not just a message delivery. And that, I think that's something we need to look at in the next few months. In terms of the check-in, how are we doing? We do have the NHS Pulse check, which comes through quarterly, and that essentially it's a bit of an indicator around those 2 recommendation questions, as well as some other bits. I think we need to use that more robustly, I guess, in terms of getting the communications out. There's always a balance between survey fatigue and pushing surveys out, but I think that previously I've used that on a quarterly basis to track progress.
Yes, sorry, Chair, if I may, just thinking about those 4 priority areas then, do you think that they are really to get to the nub of the 1 in 4 areas that we've talked about? You know, the fact that people don't respond to the survey, the fact that people aren't recommending it as a place to work, and the fact that people are saying, well, actually don't send your loved ones here. Is it really getting to that? Have we got that right?
I don't think we know until we've done that extra engagement. I think knowing, having worked at Notts Healthcare now for 15, 16 months, looking at our strategy, the staff survey, the information I have to hand at present, I would say those are the big ticket items, particularly staff availability and staff wellbeing. And if we can improve our offer and our performance in those areas, I think that then would make some progress. There's a bit about leadership that isn't referenced in detail there. I'm very much a believer that if you've got a good line manager, you tend to be happier and stay for longer. And just for assurance, that's sort of not mentioned there, but we're doing a piece of work to refresh our learning and development offer, and as part of that there is more resource going into leadership development.
Good, thank you. I'm sure we'll have more discussions at the People Committee about this.
Yeah, absolutely. And Fiona, you may well be building on some of that as well. So Fiona.
I am. Thank you, Chair. Fiona Daniel, Non-Executive Director. Jennifer, you've actually picked up on something that is missing, I think, as well, which is around that whole leadership and culture piece around staff engagement. So that will be our observations that you've already noted. I do think we need to do a lot more work there. It just seems very staff centric, but we haven't got any leadership driving a lot of the culture change and behaviour change that we need to really see if we are to achieve our strategic ambition. A question I have though is, bearing in mind the survey, the people promise, what is our ambition in connection with this? What do we want to see move, change, that we can hang our hat on and say, this is what we as a trust, that is probably going a little bit over and above what we are seeing already? What's the ambition? We talk a lot about being very focused on being innovative, doing different things. So my question really is, what is our ambition in connection with staff engagement overall that goes over and above the national survey? You might not have a thought about that just yet, so might have to reflect on, but
I couldn't find my mouse. I think it's linking back, and my thoughts, I haven't yet started in the exec director post. I've done an awful lot of reflection through the recruitment process, as you do, and as an internal candidate, I think that's really, really useful. I think it's around linking it to the strategy. So our strategy is called Making a Difference. So essentially, how do we support our staff to be able to make a difference every day? Because essentially the staff survey results are saying that not everybody feels they can. So it's unlocking that. And I think some support around hearing those voices of people who don't respond, and the data, because the staff survey can only tell you so much. It's data driven. We get free text comments, but it's not the total story, is it, in terms of staff engagement? So
yeah, exactly, and I think that's my point, is that I do feel that as a trust we do need to be putting our mark in the sand as to what we absolutely 100% want to see in respect of staff engagement, which also links back into the wider culture piece. And what are those 2 to 3 key things? Because I'm with Manjit here, just understanding big cultures, organisations, and I understand what we're saying, but we've got to test ourselves and say, are these things key culture changes that drive culture, that drive diversity, that drive inclusion? And I'm going to be really honest and say, I don't think they are. I think there's something more that we are, but we need to take time to explore, that isn't just going to come from some of the staff might not even know that themselves. I think we maybe have to be, and that's why I keep asking about this word, we might have to be the ambition to drive what we would like to see probably at a board level as well, that feeds outwardly. Thank you.
I think it's a really good challenge, Fiona, and perhaps one for the People Committee, Jen, when you're having the conversation there, to be actually doing that testing out. So if we do well on all of these things here, is that going to help us meet some of these fundamental pieces? And I think that if I've heard Fiona and Manjit properly, that's a part of the challenge in there. Stephen, let's come to you.
Yeah, this is something I've said before in other places, but one of the actions I'd really like to see us doing is to disaggregate the information that we get from the staff survey. As I understand it, we can look at individual locations, we can look at individual services, and what we're seeing in the reports are averages. And what that must mean is that around the trust we'll have areas of performance which are way above the average, and we'll have areas which are way below the average. And if we could just get into some of that detail in our analysis, we might be able to learn from areas of good practice where we are achieving good results. What are we doing well there, and is it applicable to other places? And equally, if we are finding areas where we've got particularly poor results, then it's pointing us in a very clear direction as to where we need to take corrective action. And I think the overarching actions are great, and they're all worth doing, but I think we could miss important issues if we don't get into that disaggregation of data. And I suppose the last thing before I get off my hobby horse on this is that I think the sorts of things that both Manjit and Fiona have been talking about, I believe that this kind of analysis would help you to get quicker to the places that need more attention.
So can I respond, Paul?
Absolutely. Please do.
So, in terms of the sort of trust governance, that detail, well, my understanding would be that detail will go to the people committee, and also even the layer below that. So the divisional people committee is looking at our teams. I think what I'm hearing is we need to do some of that assurance through the people committee, because it is happening, Stephen. It's just not in the board report. So I know that my exec directors are working through their results team by team, but we need to give a bit of visibility from that, from what I'm hearing.
Thanks, Jen.
Thank you.
Sue Elcock, please.
Hi, Sue Alcott, Director of Forensic Services. I was just going to say what Jen said, but I guess to give that divisional perspective, we've had our data all broken down in that way. But I think you're right, Jen, it would be good to see that and to see each other's data put all together at People Committee to help us all. But I was just going to say that that's absolutely what's happened. And it's the same in terms of we've all been asked to look at our key themes, so as then that can be aggregated. Otherwise, you'd have, an action plan with 120 plus items, for example. So thanks.
Thanks, Sue. John.
Yeah, John Brune, Chief Exec, and that is a really good conversation. This and particularly the commentary from Fiona and Manjit, I think, is really helpful, and that the sort of challenge that we want. I just wanted to add that. I think from a culture perspective and engagement perspective, the organisation is in a massively better place than it was 3, 4, 5 years ago. We've made tremendous strides to get us to here, but I can't remember where I said this either at the CQC interviews or at the board development. But we're at base camp really in terms of the trajectory of where we need to get to realise the ambition of this organisation, which is to be a great place to work, for people to be, quoting not healthcare as having got these culture bits right, and it may be that the things we need to get us from here onwards need to be supplemented by other things that have got us to here in the first place. See what I mean? It's a slightly different set of skills, and I think Jen is spot on in terms of the focus on the leadership offer. I think that's still an area where, well, we know it's not think. We know that we're quite a way behind the curve, and leadership in all its different varieties in terms of a distributed, inclusive leadership offer. And I know that Jen and her new team will be really putting some focus into that. But I think there's further conversation, isn't there, as a board, in terms of what our ambition is and what we're going to need to do. And I know people know this, but my final bit, Paul, was that sort of plea not to dismantle some of the things that we are doing because of that improvement that has gone on from where we were. Thanks.
Thanks, John. And Jen, I know from conversations we've had that you're really keen to be adding to the work that we're doing around all of these pieces. And I think that conversation demonstrates that your non-exec colleagues are also up for that as well. So I'm sure that next people committee discussion around all of this is going to be a really important piece of the picture, and I'm sure that the people committee will then make sure that it's feeding back appropriately through to board, so that we are able to, as a board, get some of those additional pieces of assurance. Great. So, and I noted the recommendations were there for us for assurance. I think we've added the piece that John's really talked to there about those broader aspirations that Fiona and Manjit in particular had challenged around as well. I know that you'll have noted those too, Jen. So let's move on to the self-certification Declaration General Condition 6. John, I think with Shirley not being able to be with us, you're stepping into the exciting limelight of this one. So over to you.
Yeah, I'm delighted to be in the limelight for this. Yeah, apologies, Shirley can't be with us today. This is a very high level formal governance sign-off for the board to approve the recommendations in the templates that follow the paper. These are what's called the annual self-certification for NHS providers to say they're compliant with the conditions of their provider licence. I'm pleased to say that we are satisfied as an executive team, and this is simply a case, well, hopefully, of the board signing off those templates. That there isn't a requirement for these to be submitted and scrutinised as there was in the past, but we are still required to publish them, and that's as much as I want to say really, Paul, on it. Thank you.
Thanks, John. I'll see if anybody's got any queries on this. I think it is a standard piece of our governance piece. What I do need though is just to get a formal indication from you, please, colleagues, whether you approve those recommendations for then being published on the Trust website. So could I just get a take from you on that, just to make sure that we're formally doing that? Great. Thank you very much. In which case, let's move on, if we can, to the subcommittee highlight reports. And colleagues, again, if you as usual, focusing in on any key things you need to tease out from the papers, notwithstanding that they've obviously been read well. So if we could start, Carolyn, with the Quality and Mental Health Legislation Committee.
Yeah, thanks, Chair. I think if I take this as read, it was a fairly short committee for quality this time, which was quite unusual for us. No real issues for escalation to the board, but there was limited assurance taken on the work that was being undertaken related to ligature risks due to the number of outstanding actions. But we did take assurance that there is a very clear action plan with regard to that, and we will clearly as a committee continue to monitor that. There is one area that we are requesting that the board approve today, Paul, which is in relation to the quality account. and we've done this before, because of the timing of consultation on the quality account and the way the data comes in, it does make it very difficult for us to formally sign this off at the board, and so we're seeking delegated authority to be able to do this at the Quality and Mental Health Legislation Committee in June, if that is acceptable to the board. Otherwise, I don't think there's anything of that isn't self-explanatory there. Thank you.
Great, thank you. Again, as you say, it's one of those things that we have done previously, and we've been well cited on the quality account. Not seeing anybody with any questions or queries about the rest of the report, Carolyn. So, colleagues, are you content to agree that we delegate authority for the final improvement of the quality account to the committee? Yeah, I think we're getting colleagues coming through on that one. Thank you very much.
That's great, thank you.
In which case we'll go to the next one, which is the Council of Governors highlight report. The only point that I wanted to tease out from this was the matter of concern around site visits that the governors had expressed a strong desire to recommence service visits at the earliest safe opportunity. And as of last week, literally at the tail end of last week, I was able to let the lead governor know that Anne-Maria did say much earlier in our meeting today that we now had a fortnight without outbreaks, and she's content for us to recommence the non-executive director service visits, which will be set up in a way that we can also offer those for governors to be part of that timetable, and there is a plan now for doing those, so hopefully that will be well received by our governor colleagues. So again, I'm not seeing any queries around that one. If we could move then to Nigel with the Finance and Planning Committee, which I think is a verbal because it was so recent. So again, if you could just give us any key highlight, Nigel, please.
Yeah, thanks, Paul. I'm sorry it's a verbal report. The meeting is an extraordinary one, not a normal cycle meeting, and it was held deliberately on the 27th of April to facilitate a resubmission of our figures on the 28th of April. So it was just last week, I'm afraid. So I do need to take you through some numbers. Hopefully I've got everybody's full attention on figures because these are important matters that we discussed and I need to report them to board. For those that can remember this far back, we did submit a draft financial plan on the 22nd of March. Sorry, I think it was the 17th of March, Alison will know, but in March we submitted a draft financial plan for 22-23, which contained a financial deficit for the year that we are now in of 5.4 million and included a cost efficiency or FIP improvement target of 16.9 million. That's where we were prior to the extraordinary meeting last week. We have now been told that NHSEI have confirmed that inflationary pressures above the 2.7% already contained in our tariff can be deemed as allowable against our control target, and those excess inflationary pressures are currently estimated to be around 2 million for the year. So the revised figures that we've submitted on the 28th of April are basically that we will break even, but we will have a 2 million deficit due to these inflationary pressures. So a deficit of 2 million with a 2 million allowable cost, which will bring us back to break even. Now that means we have had to move on our efficiency programme and increase that challenge from 16.9 million to just over 20 million, which I think we referenced earlier in the discussion today. So our efficiency requirement is just over 20 million, of which just over 6 million has already been identified, leaving us with a gap of 13 to 14 million. The conclusion the committee reached on all this was that Alison and her team have done a good job in landing our financial plan in that position, given the challenges in the system and nationally and the pressures that are on us to go further. I think we held the line very well, actually, and I think we were all as comfortable as we can be with the plan that's been submitted. But this efficiency target requirement of around 20 million, with only 6 or 7 identified so far, did lead us to conclude that on strategic risk 5, the threat to this particular strategic risk had increased significantly from where it had been in previous years. And our assurance rating has moved from positive assurance to inconclusive on threat, which is technically known as threat 5.1. So in order to close that gap and to get our assurance level back to positive territory, we've asked for a quantified plan. I think this is a question Manjit was asking earlier on. A quantified plan to close that gap and a timescale when that will be done by. Just a word finally on capital we touched on before. I think it was Stephen's question. We did also intend to approve our capital plan at this meeting, but discussions are still ongoing on capital, and we're going to need another extraordinary meeting to sign that off. But for the time being, we have a working or provisional allocation of 32.6 million for capital expenditure in 22-23. Which the committee were reasonably comfortable with, but I just need to highlight that that is a little way short of the 39 million that the trust actually thinks it needs. So there will be a need for some prioritisation somewhere along the line. Happy to take questions, Paul.
Thanks, Nigel. I think I preface any conversation by saying that I think it's really important, given the detail that you've gone in there, that as and when the minutes from that extraordinary meeting are available, if we could just take the precaution of circulating them to the whole of the board, because you know, best will in the world, that's a lot for us to grasp from the verbal report, important though it is to bring to our attention. If we can just ask colleagues to note that we'll get those circulated around to the whole of the board, I'd appreciate that. Any comments or questions for Nigel on that piece? Paddy.
So that was really helpful, Nigel, and I think we are in a tough place, and I just want to reinforce the point that Alison made earlier on in the meeting, that, you know, we need to look slightly longer than the next 12 months. Some of the big changes, I guess, are around community services and taking slack not just out of our system, but other people's system as well. And I think that's quite a big challenge for us. And I just wonder where the ICS sit in all this. The notion of the ICS was that we were going to make savings jointly across the landscape, and I wonder whether we're beginning to touch base with them about going forward.
There's a bit of rhetoric in that one, I think, there, Paddy, is there, to be honest. But Alison, do you want to give a response? Because I know that you meet with your peers. And John, it may be that you want to just give a response from the broader integrated care system board perspective, if that's okay, Nigel. Alison.
Thank you, Chair. Alison Wild, Interim Exec Director of Finance and Estates. Yes, Paddy, you're right. We do need to focus on working with our system partners to deliver financial efficiencies. I think we've got a lot more work to do in terms of that system. I think we've got 8 themes that we've identified that need some oomph behind them to move those forward as a system. And it's for that, I don't think the ICB delay of 3 months is helping that. And it's for that reason at this point in time, I've not assumed in our planning any savings coming from the system, because I think it's prudent not to do so. I would be very surprised if those schemes get moving, mobilised enough to realise any savings this year. And but so the basis of that is that if anything does come, it's a bonus to us. But I think there needs to be a bigger drive in the system, and hopefully Stephen in his new role will help us with that going forward. Thank you.
Thanks, Alison. John, do you want to add anything to that?
No pressure, Stephen. Yeah, I think I take the long view with regard to the system and the integrated care board. I mean, it's great news that they will become, you know, legal entities and start being able to hold account, and I think really underpin some of the system work, and that's been lacking by the nature of where we've been. But two things. I think there's a huge potential for waste reduction, reducing duplication, and working along patient pathways by systems collaborating better. But that potential will take, I think, some time to be realised. I think organisationally as Trust we're in a really good place, but there's a lot of work that's going to be required over the next 1 to 3 years to really start to move that forward. The only thing I'd add, I'm sure Paddy and others will know this, that there's been a real hardening at the centre in terms of tolerance of deficits, and so I think we're going to be both from a Trust perspective but also as a system under huge scrutiny that we perhaps haven't witnessed in recent times. This sort of tolerance of you know, systems and organisations sloshing around with dozens of millions deficit is just, we've already started to experience it, and I think it's going to be a really different environment to work in. Thanks.
Thanks, John. Paddy, did that give at least an initial response to your challenge there?
Well, people have answered the questions, but I'm not sure we've got the answers yet, and really pleased that Stephen's going to sort it out for us.
Thanks for that. I should say for our audience that's because Stephen is going on to be a non-executive director on the Integrated Care Board when he completes his second term of office with us. So let's move on. Thanks for that, Nigel, and we'll move to Stephen for the highlight report from Audit Committee, please.
Thank you, Chair. Stephen Jackson, Non-Executive Director, and speaking in this section as the Chair of the Audit Committee, and reporting on the committee that was held on the 14th of April. I'll take the report as read. There were no items that need escalation to the board, although during the course of the committee a couple of subjects came up that we did escalate to other committees, and they are noted in the paper. We received from our internal audit partner a draft report, which ultimately will become a final report and go into the financial statements, and that was a good report insofar as as things currently stand, we would receive an opinion of significant assurance, and that's you know, that's a good place for us to be, and a good level of assurance across the whole organisation. There is one area where I think that as an organisation we could do better, and that is in some of our response to the recommendations made in previous internal audit reports, and that is one of the items that we're putting forward for further action as the year goes on, and indeed it was one of the escalations that the committee made. Two decisions made which I think are important. One is the counter fraud plan for 22-23 was approved, and we will move forward with that. And also the committee had a look at the issue of going concern, which the committee recommends for board approval in due course when that arrives here at this board. Happy to take any questions, Chair.
Great, thanks very much, Stephen. I think you've steered us through that fine. So let's move on, if we can, then to the slightly revised terms of reference of commissioning committee. Manjit, please.
Thank you, Chair. Manjit Darby, Non-Exec Director and Chair of the Commissioning Committee. There hasn't been a further meeting since the last board meeting, but the terms of reference are here for approval, and all we've done is, after that first meeting, second meeting of the Commissioning Committee, we reviewed the terms of reference just in terms of making sure that we'd got the purpose set out correctly, the membership right, and also our links with other committees correct. So it will be an iterative process, I think, as we work through and settle into the commissioning committee, but these are here for your approval, please.
Great, thanks very much. I'm not seeing any questions or comments coming through, so and again, I think this is a straightforward piece of good governance management. So are we okay, colleagues? Give me an indication if you approve these. Great, thank you very much. Just some final pieces, just to note the glossary that is there at the back. Please do go through, and if you think if there's anything that's missing from that, please feed it through to colleagues, so that we make sure that that is as up to date as possibly can be, because I think it does help having the reference there for us to work to. I've not had any other urgent business notified to me, so I'd just like to take a few minutes to review how we just reflect on how today's public board meeting has gone, particularly in the light of our values. I would appreciate a few comments, please. So can I open that up? Who'd like to start us off? Manjit, I can see you've appeared on my screen. Manjit, please.
Yeah, thank you. I thought it was a good meeting. I think that I think that we have been true to our values in terms of having a really patient-focused meeting, and I think that's important, and thinking about the implications for patients and staff. So that sat very comfortably with me. I think that the issue of workforce and the money are two things that are staying with me, and kind of highlights the importance of the work that we do in the committees over the next few months.
Thank you. Nigel?
Yeah, thanks, Paul. I agree. It's a really complex and large organisation to squeeze into a couple of hours of public board meeting, with the additional challenge of getting through some constitutional stuff that we have to do, and be true to our governance procedures. So it is quite a big ask, and it's an even bigger ask when we're doing it over technology. So I think we've done well. I think the big issues have come out. I think they're the same ones that we've discussed before. And there is just one acronym that is not in the glossary that's been troubling me, is this thing called Desmond, which I know is not a person, because I actually saw something in the cafe at Duncan Macmillan House about it, but I think I could do with someone explaining to me separately what Desmond is.
Yeah, thanks very much. I'm sure that'll be clocked. Paddy, please.
So I'm just building on the points that Nigel and Manjit have just made. I mean, I think we've had a fairly robust and interesting discussion, both about the financial gap, but more particularly around workforce and I was particularly taken with the discussion around the staff survey, where a lot of challenges are being put up, quite a lot of discussion going on there, an agreement about how we go forward, and it just struck me that all of us are in the same place on this. We know there's a problem, we know we're working towards a solution, but perhaps we're not there yet.
Great, thanks, Paddy. And I'd add, I personally would echo that one and just say that I also appreciate colleagues taking very quick learning from the board development session we had last week, and I got a sense that the work, particularly around the staff survey piece, that's going to be a really exciting piece for us, and it's something we need to focus in on. Yolanda, let me bring you in, please.
Hi, Yolanda Martin, Communications and Engagement. It's really difficult for us all because we don't always have members of the public here, so we often forget that this is a meeting that's held in public. So for me, the one thing that I picked up is about our use of language and making sure that we are inclusive, gender neutral, and it's really hard when we're talking to colleagues and things. So that was just for me, really, to mention that. And then also, Paul, to give a plug, I know you'll hate me for it, I'm sure, the fact that we are going to have a trial not immediately, but later on this afternoon, of doing a very short video clip of Paul summing up just 2 or 3 key items from board, just to, again, make us more inclusive, make us more accessible. So thank you. I enjoyed the meeting.
Thanks very much, Yolanda. Fiona, please.
Yep, I concur with everything that has been said, and I think for me, overall, it was very well paced. We've covered a lot of ground. It seems quite scary to cover so much in a very short space of time. But one of the things, in addition to what's already been highlighted, that's been a key thing, is the beginning, and just how important our key enabler of digital is, that will make a big difference to patients and to staff. And I think to have that perspective has been really useful, and we shouldn't forget some of these key enablers that will really help us to get us to where we need to be. But yeah, overall, all good. Thank you, Paul.
Thanks very much, Fiona. I think that's a good reflection for us to finish on. Colleagues, we will be moving to our part 2 board, the confidential board. I suggest, can we take 25 minutes, restart at 5 to 1, and could somebody just make sure that colleagues, I know we've got a couple of extra colleagues joining us, just let them know that we'll restart at 5 to 1. So thank you very much. Thanks for your engagement today, and we will continue at 5 to 1. Thank you.